Thank you all so much for inviting me to present on Precise. So I'm Alan Maher, I'm a geneticist at Sydney Children's Hospital at Westmead, and I'll be talking about Precise, which stands for Practitioner Readiness, Education, Capabilities with Implementation, Science and Evaluation. It's a bit of a word salad. I'd also like to acknowledge country and recognise and pay respects to the elders and communities, past, present and emerging of the lands where we are. I'm in Camaragal in Sydney, but also where you are as well. For thousands of years, they've shared and exchanged knowledge across innumerable generations for the benefit of all. So a little bit about Precise. So what we're doing is that, so this is an MRFF funded project. We're about a year into it, and it's really got two aims. The first aim is to develop genomics resources to help support primary care practitioners, to get them ready, to improve education, improve capabilities in genomics. And the second aim is to really use implementation science and evaluation to look beyond just education, but to think about how can we improve clinical capacity for genomics in the primary healthcare sector. And so we had a number of sub-aims, which I'll go through a bit later, about identifying the gaps and the needs, and also actively engaging with GPs and consumers in co-design workshops to really work out how to produce material that's fit for purpose. So when we started to put this together, it was a little bit daunting because it's kind of a huge topic, and this is for all of Australia. Our healthcare system is so complex. We've got public health, primary care, tertiary care, universities, government, private sector. So we really tried to put together a team that included not just geneticists and genetics experts, but also industry, academia, education research, primary care providers are a real key element of our team, consumers. We wanted to have an equitable kind of focus, so we tried to focus on rural and remote partners as well as the implementation science research and government policymakers and decision makers as well. So this is a snapshot of the Precise team. You'll see lots of faces there and lots of names, but essentially we have academic GPs, academics involved in implementation science, as well as genetics and education. And also, I think the key to this project has really been the partnerships with real key partners like the College of GPs, ACRM, New South Wales Health, the Children's Hospital, but also Primary Health Network, so Western New South Wales and Western Sydney, Australian Genomics, and industry partners like Medcast and consumer partners as well, and a whole bunch of GPs, most of whom are rural, which is interesting, but also consumers on the team as well. So I won't go through this in a lot of detail, but essentially our first aim was to really look at what do GPs actually need in genomics? And so we did a scoping review, and essentially there were a lot of needs. We found about 52 papers, and we've published this earlier in the year. This is the main figure from that scoping review, which really just says that knowledge is probably the number one major issue that GPs are reporting, that I don't understand genomics, I don't have the skills to have these genetic conversations with my patients. But there's a lot of additional nuance beyond just knowledge itself that really needed to be addressed before GPs could feel confident in genomics. And so there were big needs in things like lack of financial support or access to genetic services, just the lack of time for GPs. They have 15, 20 minutes to see a patient, to talk them through a whole series of genetic tests and referrals is really difficult. Lack of awareness of what is appropriate and what should be referred or not referred, or tested or not tested. A lot of uncertainty about the role of GPs in genomics, that this is such a growing, rapidly growing field that some GPs are reporting that, I'm pretty ambiguous about what my role is here, and actually some concerns about the possible negative consequences of genomics on their patients. So there was a lot just from looking at the literature, but what we really wanted to do was to talk to GPs and talk to consumers. So we led a series of co-design workshops. This was by our postdoc, Dr. Manoush Bonakta-Tarani, but also guided by Emma Bonser from Genetic Alliance, where we talked to 12 lived experience consumers across Australia, and also 20 GPs across 4 workshops and across Australia in rural and remote. And we really tried to drill down on what they wanted and what would work for them. So, what did we find? This all happened in the last 6 months. So from the GP focus groups, we actually found a number of barriers and enablers to GPs using genomics and genetics in their scope. So the biggest barrier that they were reporting was lack of knowledge, just like our scoping review showed, but also a lot of issues with confidence, time constraints, a lot of lack of clarity about where do I refer patients, what's appropriate, what's not, what's Medicare covered, what's not, and some legal and ethical concerns. And what they told us were enablers were having clear practical guides, something that could be CPD supported, relevant decision support tools, asking a friend or asking for quick advice, and also some materials that could be patient facing as well. And so really what GPs were telling us they wanted was something that was relevant, brief and clear, accessible, interactive, and integrated into their existing software as well. We found it really interesting doing this project to kind of try and combine what the GPs were saying and also listen to what the consumers were saying, and then trying to kind of equate these two groups as well. And talking to the consumers, I think you have a lot of representatives from Rare Voices here. It's nothing new that you haven't heard before. I think the biggest take-home message from our lived experience genetics consumers was that they weren't being taken seriously by their healthcare professionals. Didn't even matter if it was their GP or their pediatrician or their neurologist or whoever. There's constant stories of minimization and dismissal, massive delays in genetic testing, no guidance, no pathway, a lot of complexity in the health system, lack of integration of their care. And so there were some massive barriers being highlighted here. Interestingly, when we asked them what they wanted from their GP, they didn't want a GP who knew everything about every rare condition in the world. That's just too much. They really wanted someone who would give them some access to care and help provide them with a support network in place. Maybe something that would help educate them, help understand the process of getting a diagnosis, some patient-facing resources, some open information and communication in a culturally safe and competent way. And so there was actually a lot that consumers actually appreciated in their GPs as well. Those who had good relationships with their GPs said that the things they really valued was not their knowledge, was not their expertise, it was actually their empathy and collaboration, that they were flexible and responsive to their needs, someone they could trust, and someone who would advocate for them. That was the number one message that our consumers were telling us. Interestingly, what they wanted from the GPs and the actual health system was longer and more flexible consultation times, recognition of their lived experience, as most of these consumers were absolutely the expert in that rare condition, probably in Australia, if not the world. And so really they realized that they wanted their GPs to realize that, they knew a lot about this condition. And interestingly, they really just wanted their GPs to listen to them and take them seriously. As I said, they didn't really care that much. They wanted basic knowledge of genetics, but it's really the care they were receiving that was the biggest issue. We tried to draw a bit of a diagram here about the fragmented journey of our patients that they were telling us about. But what essentially we've ended up doing is through these 6 co-design workshops, we've let the GPs and consumers tell us what they wanted, and then we designed it, and then we kind of fed that back to them, and then they helped us change it and iterate it. And so what we've eventually created is this genomics portal for Precise on a company called Medcast, which is a provider of GP education. And that's live now. You can actually go to that website to see it. The 4 topics that our GPs said they wanted was genetic testing in pregnancy, genetic testing just in general, referral pathway information, and also cancer genetics. So those are the 4 topics that we are focusing on, and we're creating point of care resources, so quick resources that they wanted, but also the longer format resources that they wanted in the form of webinars and e-learning modules. We're also providing some additional things that they came up with that we would never have dreamed of coming up with, actually. So here are some examples of our resources, and these are available live. So we've created a point of care fact sheet for non-invasive prenatal testing, as well as reproductive genetic carrier screening, because these are probably the 2 biggest genetic tests that GPs are involved in, probably on a weekly, if not a daily basis. For any couple who are planning a pregnancy or anyone who's pregnant, they would probably be offered or have a discussion about this type of testing. And we've really tried to keep this as short as possible. They're literally 2 pages long, and we had a lot of feedback on the formatting and how the GPs wanted the layout to be, and also trying to make it friendly for patients as well. So you can have a look at those in your own time. What I'm really excited about is something that we didn't even dream about making, which was actually a genetic testing table for GPs. Doesn't really exist out there, and I would never have thought of this, but the GPs said they really wanted a table that just showed them what can they order, what can't they order, what should they think about first, and even things like what Medicare number do I need to put on the form for my patient to get the Medicare rebate. So we've started creating this now. It's probably going to go live in about October, and it's literally a table of tests that they can order or think about ordering. You can see carrier screening obviously is green, but hemochromatosis is orange because they should think about it first. And we've got about 20 tests on that table now. So I'm not going to take up too much time, but I'm just going to say some early lessons that we've learned so far from talking to our GPs and consumers. I think the first lesson is that the health landscape is really fragmented, and more than I actually imagined, even as a medical practitioner. There are huge gaps between primary and tertiary care, patients getting lost in the cracks, and really it's impacting GPs and their access to genetic help and advice, and also patients. They're getting lost in the system and not accessing proper care. These patients want to be taken seriously and directed to a genetic diagnosis quickly, and really the system is often not helping that. The GPs we spoke to really all wanted to do the right thing, but really didn't feel enabled or supported to do this. And I think we need to think as in us in the tertiary sector, how we can probably have a friendlier approach to helping our GP colleagues to do this. And the existing systems are really not great. I worry that beyond Precise, when the funding runs out in 2 years, we really need something that can update this resource for them. And we need to think about how genetics units can interact with GPs better. The co-design process has been really, really eye-opening, talking to consumers and GPs, immensely helpful to produce things that are fit for purpose. And our next step over the next year is we're going to evaluate the whole process and the whole resource to draw some learnings.
Hi everyone, hi to my new friends and old friends that are in the chat today. So I'm a general practitioner, and I started my journey with the Rare Care Centre at its clinical inception, which was October 2022. And I am not ashamed to say that before, maybe I am ashamed to say, but before that I kind of didn't know clinical genetics was a thing. So which I think I'm not alone in lots of general practice kind of circles, and actually really possibly tertiary hospital circles as well sometimes. So it's been a steep but amazing learning curve. I'm here tonight to chat about when common symptoms point to uncommon diseases and what we can do as GPs with our detective toolkit. So I'd like to, I don't know if mine's working, here we go. I'd like to get on to the next slide. Sorry, BBC acknowledgement, thank you. Acknowledgement of country. So I'm on Wajak Noongar Boodja, which is over in Perth. What we know about rare diseases, which if you're a frequent flyer on the Project Echo, you will know already, but just a refresher for some newbies here, is that it's a disease that affects less than 1 in 2,000 people. So there are about 8,000 known rare diseases and kind of increasing. So they are individually rare but collectively common, affecting about 300 million people across the world and 2 million in Australia. About 80% are of a genetic origin, hence our kind of a bit of a focus on clinical genetics, and 70% are in childhood, and I work for the Child Adolescent Health Service, so we focus on kids. The main thing I think tonight where we're looking into is this concept of a diagnostic odyssey that may be able to be shortened by kind of early intervention through GPs and early recognition, really, because we are the primary source of contact, and sometimes get a lot of information from different sources. So on average, it takes 5 to 7 years to make a diagnosis for a rare disease, and we're really looking to kind of shorten that in ways we can do that. About only 5% of rare diseases have a prognostic altering treatment, but of course there's many kind of symptomatic treatments and therapies that can really help improve the quality of life of these children and adults with rare disease. 6 out of 10 deaths in children are due to a rare disease, and it is the biggest cost in the healthcare system, 1.5 times everything combined. That's on US numbers. So when you think about, is it rare? Could it be rare? We think about red flags, and they can go by the mnemonic family genes, okay? So as you can see there in the outset, family, is there a family history? Okay, you can take a family history a few generations back and think, was there maybe a sudden death in infancy in an uncle? Was there an epilepsy diagnosis somewhere else? Is there an intellectual disability diagnosis in a grandfather or something like that? Is there some sort of family connection? And in medicine, we will all know that, common things are common. So we're taught to think what the common things are, and they are horses, but sometimes it really is just a zebra. And we've got to look for those zebras, and how do we spot that? We look at a group of congenital anomalies. So an individual congenital anomaly like an atrial septal defect in congenital heart disease, for example, is common. But if you paired that with another congenital anomaly like a cleft palate, then the likelihood that there's an underlying rare disease becomes much higher. They can present with ease, so extreme or exceptional presentations of common illnesses or common diseases. So, for example, in adults, maybe it's early onset cardiovascular disease or particular types of early onset cancers. So we're talking about cancer genetics before, or early onset renal failure. If they have sometimes in childhood an unusually severe reaction to an infection, like a common infection like gastroenteritis or a metabolic stress, you might think, this is a bit different. Kids don't normally act this way. Maybe you have a lady with a recurrent miscarriage. Maybe you've got bilateral primary cancers in the same organ, paired organs, or maybe you've got multiple primary cancers and maybe you're thinking, hey, there's something else going on here. Could it be a rare disease, underlying cancer, predisposition? In children particularly, we look at neurodevelopmental delay, and usually in and of itself, you could start to look at tiers of testing for that. It's really important to note that if there's neurodevelopmental degeneration, that is a child has learned a skill and then regressed, so neurodevelopmental regression, then that is a very high likelihood that there's an underlying rare disease and concern for a genetic disorder. Extreme or exceptional pathology in histopathologies like a phagochromocytoma or an acoustic neuroma and things like that, plexiform neurofibromas, those kind of things. We think, is there an underlying rare disease here? And if you get surprising lab values, so if there's markedly abnormal pathology results, maybe there's a really high lactate when they're unwell or something like that, might point to like an underlying metabolic disease, which is when, again, I'm in trouble. So if we have a patient in mind and you think there's just a few things that are adding up to, I don't know what, where do I go? What do I do? Who do I ask? So there's a couple of online resources which are really good uses of kind of, I guess, AI. Find Zebra is looking for that zebra among the horses. So it's a rare disease search where you can put in the presenting kind of complaints. So maybe they've got atrial septal defect, cleft palate, developmental delay. You pop that in and it will come up with some options for, it could be this, it could be that, it could be the other, and you can go from there. OMIM, similarly, you can put in some clinical features, or you can search for a known rare disease. So if your patient has a rare disease that you know already, but you want a bit more information, then you can pop it into OMIM as well. And alongside, I'm really excited, and I say about sort of Alan's all the work that's been put into the Precise and the kind of resources for GPs. Currently, we have this little booklet called Genomics in General Practice, put out by the RACGP, which is a really good first point of call and probably a good start, and then move on to when all of Alan's kind of resources are up and running completely. But it really does go into a little bit about some of the things that Alan said and a little bit of a snapshot. So preconception counselling, non-invasive prenatal testing or screening, like things like insurance implications for genetic tests, what might you find on a genetic test, and a few things about what next maybe for a person you think might have a rare or undiagnosed disease. So I'm going to go focus briefly back to children, although this is relevant for adults that have not had kind of genetic testing before as well. So there may be patients that you know in their 20s and 30s that didn't have access to genetic testing at the time that you might be able to help out here. But chromosomal microarray, excuse my general practice dumbed down version to the clinical geneticist on, but essentially it's a first line test for individuals presenting with either developmental delay, intellectual disability, autism spectrum disorder, or multiple congenital anomalies. So again, looking at those red flags. It's Medicare rebated for the above conditions. A GP or a non-GP specialist can both order it with a Medicare rebate. It is a limited test because it only tests for variations in the DNA copy number, so it can identify large deletions or microdeletions and large duplications or microduplications. Most abnormalities in chromosomal number, like T21 in Down syndrome, and some unbalanced rearrangements of chromosomes as well. What it doesn't test for, which would need to be added on separately if you were doing a form, is Fragile X. So I think GPs will be very well aware of this as part of the 3 gene carrier screen for prenatal testing. Fragile X syndrome is the most inherited cause of intellectual disability and the second most common cause overall. I think second period into T21. RACGP does have a recommendation in their genomics to test individuals with developmental delay, intellectual disability, and autism spectrum disorder. But I would be mindful that out of those 3 indications is only Medicare rebated for intellectual disability, as ordered by a GP anyway. Just a little note, it's got an interesting kind of underlying genetics. So they depends on the copy repeats, I think, in the FMR1 gene. So you can see there's a usual number of repeats, 5 to 54. Fragile X syndrome, which is the intellectual disability kind of linked, is if you have more than 200 copy repeats. And there are some other Medicare rebatable reasons that you can order, looking for the pre-mutations, which include kind of ataxia and primary ovarian insufficiency, for example. GPs can also order if a relative has an FMR1 mutation already. So that's called cascade screening. So we can do that for family members. The case is a 12-month-old girl with developmental delay, predominantly gross motor. So she was 12 months when she came to the rare care centre. So she had Mum had an unremarkable 3rd pregnancy. She had reproductive genetic carrier screening with 3 gene tests, which in addition to Fragile X, also tests for SMA and cystic fibrosis, all were normal. She had a low-risk NIPT or NIPS, a normal anatomy scan, abnormal newborn screening. But at 6 months of age, she presented to the GP for routine vaccinations, but unable to sit supported. And the parents had delayed the introduction of solids because actually she wasn't really supporting her head much at all. Around that time, she had an influenza infection followed by RSV, bronchiolitis, and was pretty unwell in hospital, required an inpatient admission with oxygen and nasogastric feeds. At 7 months of age, she's still unable to sit, supported. Oh, yeah. So she still can't even sit in a supported environment. She's reviewed by the GP who says, look, this is not quite right. Maybe she's got some abnormal palmar creases. She's got a pectus excavatum. She's got low tone. There's something maybe going on here. It's not quite adding up, but I don't know what. And she was referred to a private paediatrician. She was reviewed same month, reported no immediate concerns from the paediatrician. She represents to the GP with ongoing gross motor issues, and she's still able to sit unsupported at 9 months of age. So for the GPs in the audience, this is something I love to steal from the Queensland government because they do a great snapshot of development, and it's tricky to remember what you're supposed to be doing when. Highlighted the flags here. So at 6 months, she's got really no head control, even in supported sitting. 9 months, she's definitely not sitting independently without support. She's struggling even with support. There's strong parental concerns here, right? This is their third baby. They've had 2 children previously. All have progressed developmentally normally. This is different, and also has some low tone. So I wanted to throw to the GPs, or what could you do next? I'm mindful there's not one right answer here.
Options are many. Anyone have any inklings, even from the previous presentations, where they would begin? Clicking through to see if anyone's hand is up. The silence on the courtyard, Sister Claire, so why don't you go ahead and tell us what you would do?
Okay, so the GP, I'll tell you what the GP did. It wasn't me. I can't take credit for this. So she re-referred. So she re-referred to the tertiary general pediatric service. And she was sort of saying, this child, you know, she gets recurrent respiratory infections as well as a pectus excavatum. Can you look it up? I don't know what's wrong, maybe, but there's something going on. Child attended the pediatric outpatient appointment at 12 months of age, so reasonable turnaround there, considering some of the wait lists in our country. But it was 3 days after a recent ED presentation for vomiting illness where she'd been sent home by ED, reviewed the next day by the GP, who said, look, you're seeing the pediatrician tomorrow. If you can just wait for that, just wait for that. She went in and she saw the pediatrician, and she got admitted directly from our outpatient clinic to the hospital. She had some further investigations. Essentially, this is an extreme or presentation of a common illness, in addition to all the other signs. So there were some flags going up there. She had a normal chromosomal microarray and had a metabolic screen, which was strongly suggestive of GM2 gangliosidosis, which is Sandoff disease. She had a confirmatory kind of ophthalmology review, which has confirmed some cherry red spots, which are characteristic in this condition. And it was later confirmed on diagnostic genetic testing. So it was a presumed diagnosis based on the metabolic testing and the ophthalmology review and her presentation. So a clinical diagnosis and then a genetic diagnosis later. And the parents were later confirmed to both be carriers. So Sandoff disease is a neurodegenerative disorder. It's caused by a variant in the HEXB gene, and it's autosomal recessive. So usually both parents are carriers, and therefore there is as you can see there, 25% chance that the child will have a condition, 50% chance that their child would be a carrier but not have the condition, and a 25% chance that the child does not have the condition and is not a carrier. It's unknown prevalence, but it's thought to be about 1 in a million. Typically, there are 3 kind of forms of Sandoff disease, but in the acute infantile, which this child has, it's normal development up until about 3 to 6 months of age, and then development slows, muscles used for movement weaken, and then there's a really quite rapid decline, generally resulting in seizures, visual impairment and hearing loss, intellectual disability, and children don't usually survive past their 2nd or 3rd year of life. So it is really devastating disease. And so I am going to ask this question about, you know, do normal screening tests, so mum had, you know, a lot of the things done in pregnancy that could be done, everything pointed towards a normal pregnancy, normal baby, do they give false reassurance to patients and clinicians? And we as GPs, if we don't have the time to go through what is, what are the implications? Is it 100%? No test is ever 100%, this kind of thing. Are we setting ourselves up and other people up for this false reassurance? I do have that in this case, so that the parents were offered the expanded carrier screening, which would have picked it up, but there wasn't. They had a chat about it and had good counselling about it, and they thought, well, we don't have any family history, like you said, there isn't really much there. It's I'm sure it varies. You said $1,500, $600 in WA to get the expanded carrier testing, and they decided not to do it. And really that was the hardest point in the whole journey for this mother, because she felt like, it's mainly put on the mother to decide, and maybe a partner would be like, oh, whatever you think, but that's a really hard thing when you have, made a decision that leads to this. It's obviously very rare. There was no family history in their family, but really the hardest thing to kind of get her head around. In addition, there's lots of to and froing. So some of the obstetric colleagues will say, but the pre-test, the sensitivity and specificity is not as good for those tests. It's good for the 3. It's good for the trisomy 21, 18, 13. It's good for the non-invasive prenatal screening, but not as good for expanded carrier tests. So are we creating more, anxiety in pregnancy if we test, but it's not that, and it's all these kind of things? So there's lots and lots to think about and unpick, which is really, really hard when this is one component of a pregnancy that we are looking at. GPs have to do extended, like we're testing for syphilis more often because that's higher. We have to keep up with what the new gestational diabetes things are. We have to keep up with this, that, and the other. And I think it's actually a really big space, and particularly goes to that thing that you were talking before, Alan, is really, really underfunded in general practice. So we don't have the time funded to do this for parents and mothers to the extent that really it should be able to be done. And I feel like that's an indictment on our Medicare system.